next recording is the approach to the pregnant woman in primary care. I'm going to start off with a very quick pregnancy review. So I want you to know that most of the questions that will be on your APEA exam for this topic, as well as most of the questions that will show up on your certification board exam at the end of the year, will be related to the prenatal care schedule. So a couple quick concepts that you need to know. The average pregnancy lasts between 37 and 42 weeks. I would even narrow this down a little bit more and say that the average pregnancy lasts between 38 and 41 weeks. However, anything between the time duration of 37 and 42 is considered a normal pregnancy. First trimester sometimes varies in the literature. Usually it's weeks 1 through 13, sometimes weeks 1 through 14. The second trimester is 14 to 27, and the third trimester is anything after 28 weeks. So we like to think of the 40 weeks as being a normal pregnancy, and anything over that is overdue. And that's just really not all that true in terms of medical care. So anything up to 42 is considered normal. We rely on pregnancy dating so that we can estimate how far along a pregnancy is, because this guides our screening procedures, and it also helps us to determine what interventions are appropriate and what development of the fetus is appropriate given how long the woman has been pregnant. However, all due dates are just an estimate because, as we discussed last week, because different pregnancies will start at different times within the menstrual cycle. So different luteal phase lengths, different follicular phase lengths. There can be a little bit of variation in terms of how good our estimate is. Most of the time, we use a prediction rule that includes a last menstrual period, and then you add a year to that, subtract 3 months, and then add 7 more days. This is a pretty good estimate if a woman has regular menstrual cycles. If a woman has irregular menstrual cycles, this is not a very good way, which is why for almost all women, we recommend an ultrasound at some point after 6 weeks gestation, because we can look at the fetus on ultrasound and or at the embryo on ultrasound and get a better idea of how far along the pregnancy is. Again, the prenatal schedule is going to be the most important thing for you to understand about pregnancy, because this is what's going to show up on your board exams. The first trimester, usually a woman will have a total of 2 to 3 visits, and the first visit usually happens between weeks 4 and 12. Most of the time, if you call a pregnancy provider, especially in a bigger city where there's a higher number of pregnant women, if you call the provider and say, "Hi, I just had a positive pregnancy test," they'll say, "Okay, we want to schedule you for an appointment sometime between 7 and 12 weeks. So they normally won't see you that early. Sometimes you can get an appointment with a nurse who will just give you some prenatal education, maybe help with a little bit with medication advice earlier on in the pregnancy before that first visit. But most of the time, they don't want to see you until closer to between 7 and 12 weeks. And then at that first visit, they'll do an ultrasound and all of your blood work. Usually the first trimester, you'll have 2 to 3 visits about once a month. That continues in the second trimester. Starting at 28 weeks, we like to see that woman every 2 weeks, so a total of 4 visits. And then we like to see the woman weekly between 36 and 41 weeks. Typically, that means that you'll have 1 to 5 additional visits at that point. If a woman's pregnancy lasts after the 41st week, most providers will have the woman check in a couple of times during the week at least. Sometimes they'll do non-stress tests, which is a way of monitoring the baby's heart rate and making sure that they're getting enough blood supply and that the placenta is still working well enough to keep that baby healthy. Okay, so some things that women need is just basic guidance on how to manage a healthy pregnancy. So most of what you're going to be doing with pregnant women in prenatal care is providing education. So you need to make sure that they understand how to use medication safely. They need to be reminded about seatbelts. They need to be assessed for interpersonal violence. They need to be told to avoid things like excess heat, ionizing radiation, certain foods that carry a risk of things like listeria. So typically listeria comes more from unwashed vegetables than it does from things like deli meat, but we still recommend that women avoid things like deli meat. Women need to avoid high impact exercises and be careful of activities that can cause falls. So, for example, riding a bicycle is not the best activity for a pregnant woman. Most women are able to continue doing whatever exercise they were doing before in terms of physical exertion, but you do want to just make sure that if they were doing something that is high impact, for example, kickboxing, things like that may not be the best activities while pregnant. Most women do not have any sexual restrictions during pregnancy unless there's an issue later on in the second and third trimester. Sometimes we'll limit sexual activity in the first trimester if a woman is bleeding. And those are kind of case by case bases depending on what we think the issue is. Some women will have workplace restrictions, for example, women who work in factories with certain chemicals, women who work in highly dangerous areas. So, for example, if a woman is a nurse and in the emergency room, she may need to be careful about interpersonal violence from patients or lifting restrictions, things like that. Women need to be told how much caffeine is acceptable. Typically, 100 milligrams of caffeine a day is fine. Women should avoid alcohol and drug use, especially in that first trimester, but continuing on throughout the pregnancy. There is some debate in the literature about alcohol, and the best advice that I can give you is that you should help women understand the risk of alcohol use in pregnancy. That is, there is no amount of alcohol that has been demonstrated to be safe in pregnancy, and we're not sure where the threshold is of damage as far as alcohol use. So it's better to avoid it entirely than it is to risk that damage in most cases. Women should be told about the common complaints of pregnancy, and we'll need some information about managing these, and that's what your second lecture is this week. And then they should be given information about what symptoms to report and what to do if those symptoms occur. So, for example, if they're having uterine contractions in the second trimester, this can be concerning. If they're having uterine contractions at 38 weeks, this is less concerning because it's expected, and they just need to know where to go and what to do about that. Things like calf pain, need to be told the difference between just cramping in the calves and signs of DVT. And then finally, they need to understand the labor process. So when to call the office versus when to go into the office or when to go into the hospital for labor and delivery. Okay, so some important concepts of pregnancy. As an FNP, your scope of practice allows you to provide preconception care. You're allowed to diagnose a pregnancy, and in many cases, women will come to you with some symptoms that they're not sure how to interpret, and you may be the person who helps them identify that they are pregnant. And that may or may not be something that they want to identify or that they were intending to do. So you may have to provide that support for them in management of whatever that reaction is to help them come to terms with the situation and proceed however they would like to proceed. You can provide prenatal care. Typically, that prenatal care will happen in the first and second trimesters. And then around the third trimester, you will start to hand off care to a provider who can perform a delivery. Most complications of pregnancy will occur in that third trimester as well. So it can be helpful to have a specialist involved in case those things were to come about. You can also, at any point during a pregnancy, provide primary care for a pregnant patient. So if a woman has an injury, an acute illness, or if they have chronic conditions that require management, even if it's something like seasonal allergies, things like that, sometimes pregnancy specialists don't have as much training or don't keep us up to date on the literature and these just common everyday concerns that are not pregnancy related. So you may be the expert on dealing with those things, and you need to understand how to deal with them in pregnancy. One thing we don't do very well in the United States is help women postpartum to kind of adjust to being a new mother. And so you may be the person that they call when they need guidance in postpartum. And then lactation can last anywhere from a few days to a few years. And so you may resume care of a patient who's still breastfeeding a baby. And you need to know what the advice is for taking care of those patients. I just want to make a quick note that we medicalize pregnancy in this country. However, pregnancy, labor, and birth are all normal physiologic processes. And so most of the time, women only require monitoring and education as opposed to intervention. Most women, if you leave them alone, they will pretty much be okay through a pregnancy. Certainly, that is not the case for all women, and that's why we keep such close tabs on moms and their babies when they're pregnant. However, most of the time, pregnancy, labor, delivery will occur naturally without any assistance or intervention from a provider. Okay, so one of the things that nurse practitioners really need to understand is how to advise women about medication use in pregnancy. So almost all women who are pregnant will need or use a prescription medication at some point during a pregnancy. The number of people who take over-the-counter medications is probably even higher than that. Most women will take 3 or more medications that are prescribed during the 9 months of their pregnancy. These may include vitamins like prenatal vitamins, supplements, so things like folic acid and iron, GI medications like antacids or antiemetics, antibiotics for acute infections. They may take pain control medications such as acetaminophen, NSAIDs, or opioids, and they may need antihistamines. These are the most common ones, but there are certainly other ones as well. Okay, medication safety. You guys have all taken pharmacology more recently than the last time that I took pharmacology. When I was learning about pharmacology in school, we were still using pregnancy categories. You may or may not have learned about the pregnancy categories, but from 1979 to 2015, the FDA would require drug companies to assign a category based on the studies that were performed during the drug testing phases. And the category would say whether or not research had been conducted in humans or if it had only been conducted in animals. And then whether those studies, whether they were in humans or in animals, showed any risk of damage at all to the fetus. So only medications that were category A were tested in humans, which means that the number of medications, um, well, so only those were tested in humans. Category B was tested in animals and did not show any risk to the fetus at all in an animal. C, D, and X were not tested in humans. There was some risk to the fetus, whether that was in animal studies or not. And so the bottom line is that most of these medications were classed as C, D, or X just because of the way that the categories were created. Now, when we say risk to the fetus, everybody gets their hackles up and gets very anxious about this. But adverse effects to the fetus could be things like they could be pretty small things. They're not necessarily all things that are going to cause long-term concern. And also, we don't know that these medications would have caused problems in humans as opposed to just animals. So basically, this system didn't work very well because it classed way too many medications as C, D, and X. So, additionally, because drug companies wanted to avoid liability, most medications would be classed as a C just so that the drug company wasn't responsible if any damage did occur. And then finally, most drugs released between 2000 and 2010 were never studied in pregnant women because of human rights protections. We stopped doing research the same way. All of this led to, in 2015, the FDA came up with a new system that requires companies to discuss the risks of these medications in pregnancy, lactation, and reproduction based on any studies that have been done in patients, even including those that were performed after the drug was released. Okay, so the safety considerations that we look at when we're talking about medication use in pregnant women. Does the medication cross the placenta? If the answer is no, it's not going to affect the fetus. The other question, though, that you need to ask is some medications will not cross the placenta, but will diminish the amount of blood flow to the placenta, and that can cause damage as well. So I probably should have put that one on here as well. The next question is, how is it going to affect the fetus? So teratogens are going to impair the development of fetal organs, which is why we have even more restrictions on first trimester medications. Most organs are formed in the first trimester. Adverse effects then can cause some organ dysfunction after formation. And these are the ones where they may cause, quote, risk, end quote, to the fetus, but they may or may not be significant in the long run. The next question is, how much data do we actually have about this drug, and how strong is that data? So most of the data that we have on medications are from case control studies or post-production data after the drug was already released, or from risk reporting. And so these are not randomized control trials. These are not level 1 evidence like most of the drug research that we see before a drug is released to the public. And then finally, we always have to consider the risk and the benefit for the mother and the fetus. So if the mother is in a life-threatening situation and the only medication that's available to help her is a category D medication, the risk is probably going to be less than the benefit, and we're probably going to give that medication. Because if the mother dies from not getting it, then the fetus is not going to do well anyway. So we need to give that mother the medication, even if there's some risk to the fetus. So the new FDA pregnancy risk data, each medication was reevaluated by the drug company. So the FDA required each drug company to go back and reevaluate all of the literature that has since come out about their drugs, and to enroll these medications in a pregnancy exposure registry where women can report side effects or concerns from drugs they're taking after they become available on the market. Each drug then has a risk summary. So instead of a category, there's a specific information provided about the teratogenicity of the medication, any adverse effects, and where that data came from. Some of that will come from human or animal research, and then some of that data is just theoretical, meaning that based on the way that the drug works, this is what we think would happen in a pregnant woman. And then finally, there's information provided about clinical considerations. So they needed to report on what might happen if the disease was untreated with the medication, if there's any dosing considerations for the pregnant woman, what the adverse effects are for the mom and for the baby, and then how the drug might affect labor and delivery. So the idea is that for each drug, all of this information should hopefully be available or is coming available, and the clinician can use this information to better understand the whole picture of risk besides just a letter category that may have been misassigned. Okay, so these are the overall important concepts that I want you to take with you as you're starting to think about pregnancy. That your next lecture is going to be all about the different issues that can come up during pregnancy. As always, if you have any questions, you can write them down and bring them to class, or you can post them on that 24/7 office hours discussion board. And I will catch you on the next lecture.